Good morning. I am Dr. Kélan Bertille, anaesthesiologist from Burkina Faso, West Africa. I do thank the track chair and the scientific committee of the World Congress of Anaesthesiologists 2021 for the honor to give this talk. I have no conflict of interest. Trauma is a leading cause of morbidity and mortality in children. After a major trauma, a multifactorial global failure of the coagulation system to sustain adequate hemostasis can occur, called trauma-induced coagulopathy, TIC. TIC is frequent, and it has been identified as an independent predictor of mortality with a mortality rate of 22%. There is no universal and unique definition of TIC, scores being based on conventional coagulation tests, platelet functional tests, thromboelastography, and clinical parameters. In contrast to adults, in children, traumatic brain injury seems to be the most common trigger of TIC and mortality. Tissue injury and hypoperfusion stimulates the endothelium to release thrombomodulin, which interacts with thrombin to activate protein C. Activated protein C inactivates factor 5 and 8 and consumes plasminogen activator inhibitor 1, leading to hypocoagulation and hyperfibrinolysis. TIC has also a iatrogenic cause due to dilution of coagulation factors secondary to fluid administration and massive transfusion. Other causes of TICs are impairment of platelet function, metabolic acidosis, and hypothermia. However, hypercoagulability with thrombosis can be observed in pediatric trauma patients. An adapted and early hemodynamic and hemostatic resuscitation is required to improve prognosis in critically traumatic patients. In adults, damage control resuscitation strategies improve outcomes. The effectiveness of a goal-directed approach in children remains to be more proved. Massive transfusion protocol aim to minimize coagulopathy by the early replacement of coagulation factor and platelets. In adults, in 1:1:1 red cell, plasma and platelet ratio is commonly used and is also proposed in children. However, in pediatric patients, no improvement in mortality rate has been noted with massive transfusion protocols, and no association between specific blood product ratios and survival was found in children. Fresh frozen plasma is the most common blood component transfused to treat coagulopathy. But in children, its administration can readily provoke circulatory overload. It was then proposed to use it only in case of active bleeding in children. Whole blood at a dose of 20 milliliters per kg has been successfully used, but the evidence is still scarce. In massive transfusion, the first coagulation factor to be depleted or diluted is fibrinogen. Therefore, it is essential to replace it, ideally guided by frequent thromboelastography controls. The use of recombinant factor 7 for pediatric trauma is off-label, but some published data exist on its use in pediatric. There is a lack of studies concerning prothrombin complex concentrate in pediatric trauma patients. At high doses, it has been associated with thromboembolic events. CRASH-2 study showed tranexamic acid efficiency in adults with trauma, but in children, studies are less unanimous. The rapid realization of the thromboelastography will better direct its use. This drug is cheaper. The total cost is about $2. As a result of the CRASH-2 study, the WHO put tranexamic acid on the list of essential medications, and it is recommended to administer this drug early after a trauma. To prevent stored blood from clotting, it contains a calcium chelator like citrate. Hypocalcemia is poorly tolerated by young children. During massive transfusion, calcium must be regularly given based on hemodynamic and blood controls. Temperature must be maintained at its normal values. Rapid control of bleeding is a key to survival. Damage control surgery is better than repair surgery under acquired circumstances. Here is the damage control in children protocol proposed by the ADAPF. It includes many points, such as administration of tranexamic acid, prevention of hypothermia, control of bleeding, volume loading, hemodynamic goals, etc. As reminder, young children are sensitive to cold, hypocalcemia, acidosis, and circulatory overload. Stored blood contains high levels of dextrose, and children do develop reactive hypoglycemia. Under notice during anesthesia, this can lead to brain damage. It also has high level of potassium, the cardiac antidote of which is calcium. TIC management in our countries remain a real challenge. However, some rather simple strategies can help. The key to success is to define a coordinated multidisciplinary approach involving all actors: emergency room, surgery, anesthesia, nurses, blood bank, lab, and pharmacy. First, some components must be available on a 24 hours, 7 days a week basis: tranexamic acid and calcium, two low-cost medicines, either the three blood products, red cell, plasma, and platelets, or whole blood, either fibrinogen or lyophilized plasma. In addition to common monitoring, including diuresis and temperature, there is a need to rapidly and repeatedly measure hematocrit, potassium, and calcium. Blood gas analysis, thromboelastography, and rapid platelet function measurements are financially and technically out of reach. It has been proven that the mere existence of well-prepared and agreed-upon procedures improve survival regardless of the locally available technical means. Such procedures must be regularly reassessed. In conclusion, prevention is the most important treatment of coagulation abnormalities after pediatric trauma, including early actions such as administration of some drug, tranexamic acid, and fibrinogen. Thromboelastography on admission is essential to target the coagulation defects. As data in children are still scarce, studies are needed. In total, the key is to win time and to increase attention to physiological details. Thank you for your attention.